Reducing Heart Failure Readmission Rates, a Dual Approach by Nicole Kwiatkowski. The purpose of this project is to explore how the initiation of heart failure education throughout hospitalization may reduce readmission rates compared to the initiation of education at discharge in a local community hospital. Heart failure affects 5.7 million Americans. 1 in 4 of these patients will be discharged with the diagnosis of heart failure and readmitted within 30 days. According to the New York State Department of Health, Mount St. Mary's Hospital, a local community hospital, reports a 20.5% 30-day readmission rate between July 1, 2013 and June 30, 2016. This is consistent with statewide averages reported during that period. Costs from heart failure are estimated to be more than $33 billion, and that number will likely grow as our population ages. It is so important for patients to understand just how important basic discharge instructions are, such as monitoring their weight, watching their sodium intake, follow-up appointments, and even just taking their medications as prescribed. Many of these topics can be discussed at follow-up, but the time between discharge and appointment are crucial. In the Catholic health system, patients must receive 60 minutes of heart failure education before discharge if diagnosed with heart failure. This is sometimes a difficult task for nurses, and information might be given quickly, or the patient may not admit they don't understand it. This might leave many questions that go unanswered. These concerns pose a great opportunity to improve heart failure education for our hospitalized patients. This leads to the clinical question: in heart failure patients, are hospital readmission rates improved when heart failure education is initiated upon admission, compared to later initiation of education beginning upon preparation for discharge? Searching for evidence for this project was actually somewhat difficult. There are many studies done on education techniques for heart failure, but not many on early education during hospitalization or on education throughout the admission. A CINAHL search using the keywords heart failure and education, limited by selecting articles from 2012 to 2017, those in English, based on humans, and containing literature from academic American journals, with exclusion criteria of articles with a level of evidence greater than 3, dissertation papers, CEU credits, and magazines, yielded 45 results. One of these results was used for final analysis. A second CINAHL search using the keywords readmission and heart failure and education, with the same inclusion and exclusion criteria, displayed 18 results, 2 of which were used in final analysis. Lastly, a PubMed search using the keywords heart failure and education and readmission, with inclusion criteria of publication within the last 5 years, humans, and clinical trials, with exclusion criteria containing a level of evidence greater than 3, published prior to 2012, provided 26 results, 1 of which was used for final analysis. The results were a total of 4 articles used for final analysis. 2 of these articles proved to be very helpful in identifying a possible solution to the clinical problem. Sales et al. Indicates that specially trained volunteers may be a reliable way to reduce 30-day heart failure readmissions. 7.1% of test participants who received additional heart failure education and guidance by trained volunteers were readmitted within 30 days versus 19.4% of participants in a control group receiving standard discharge instructions. The Bassour et al. Study used a checklist system in a community hospital to ensure that all heart failure medications were appropriately prescribed, along with teaching and referrals being completed. The checklist group had reduced 30-day readmission rates as well as improved 6-month readmission rates compared to the control group. Readmission rates for the test group were 2% within 30 days and 23% within 6 months versus 20% within 30 days and 42% within 6 months for the control group. The remaining studies did not seem to have results impacting readmission rates, but did indicate that additional time spent on heart failure education and screenings for cognitive impairment improved patient understanding of heart failure and improved patient outcomes. Overall, after comparing these 4 studies, Data indicates that implementing improved teaching and education tracking methods as standard care might be a cost-effective method to reduce hospital readmissions for heart failure. Recommendations for this study include a checklist system in addition to using trained volunteers, which might be a great fit for a community hospital to reduce heart failure readmission rates. The checklist system should be implemented for all patients admitted with a diagnosis of heart failure. Additionally, patients willing to participate in an enhanced heart failure education program should be assigned volunteers who might assist in heart failure education. Volunteers should complete and pass a heart failure education program and will use supplied materials to facilitate patient education and understanding. The studies used for analysis indicate that further research should be done to improve upon the results recorded. Therefore, IRB approval is recommended to implement a small pilot study on a cardiac telemetry floor before hospital-wide initiation. Following this approval, an in-service should be provided to clinical staff, including providers and nurses. This can be done on a rotating basis to prevent shift disruption. Staff will be provided with data sheets displaying the positive data reported by previous studies, as well as current readmission rates for heart failure in the community hospital setting. An outline of the proposed study will also be provided, highlighting the benefits to patients and the minor changes to be made for staff. The checklist will serve several purposes. For physicians, ensuring that recommended medication guidelines are followed and that suggested orders are in place based on patient condition and need will be necessary. Nurses are to sign off on nursing education and ensure that adequate time has been spent discussing appropriate topics with patients and their families. Nurses may also use the checklist in addition to the EMR to suggest both inpatient and outpatient referral programs depending on their assessment. The checklist assessment will not incur significant additional costs, but will require staff participation to ensure that it is implemented correctly. The volunteers may ask patients about their understanding of heart failure and provide answers from the education packet they have received for teaching purposes. Additionally, they might be a great tool to advise nursing staff of difficulty patients express with their medications, diet, or weight monitoring, or just general understanding of heart failure. The nurses should follow up on these concerns to ensure that teaching is provided accordingly. At discharge, patients will be asked to complete a survey to rate their experience with volunteers and describe their understanding of heart failure management at home. Additionally, the patients who do not receive volunteer services will be asked to complete this questionnaire to report their understanding of heart failure management as a sort of control group. Each pilot study should run separately for 3 months. If both programs seem to provide favorable results in the community hospital setting, a larger combined study should be done on the cardiac floor. This study should last about 4 months to ensure that data is informative and insightful. The data will be reviewed just as in previous studies, searching for data correlation. Determination of costs in association with benefits will also be made using qualitative data from the checklist study, as well as both qualitative and quantitative data from the volunteer study combined to determine whether the implementation of both studies has a positive impact on readmission rates. Readmission rates will be monitored carefully during this time. Participation from physicians, hospitalists, nurses, and volunteers will be a key component to the study. The design of this possible new policy is meant to be cost-effective without adding additional strain to nurses and providers. The cost for the program will be presented in the form of educating volunteers, adequate supply of heart failure education materials, and additional printing needs for checklists. A cost determination study must additionally be performed, although in theory, as readmission rates decline, any hospital-associated costs for the program will be minimum. To encourage continued participation from staff, frequent updates will be provided along with positive patient testimonials. Compliance and teamwork between staff and volunteers will be recognized. Data will be displayed monthly in a hospital newsletter. Staff will continue to be encouraged to discuss their opinions, ideas, and thoughts for improvement with the team. In time, the study may become a policy that can truly help heart failure patients understand their care and disease process, which in turn will hopefully reduce heart failure readmission rates.